We can make a start. Joe, Anjana, can you just make sure that you can see that on the screen in full?
Yes, we can. Thank you, Sarah.
Lovely, that's great. So please feel free to leave your cameras on or turn them off if you prefer. We do sometimes find that when we're playing the clips halfway through, which we've got a couple to share with you, that it affects the bandwidth slightly. So when we start to play those clips, it might be useful for you to turn those cameras off at that point. It does sometimes just improve the signal. So in terms of confidentiality, we have got a couple of case studies to share with you all. Just please be mindful, obviously the cases are anonymised, but just to be respectful of the confidentiality in terms of sharing the information that we are sort of sharing with you, and acknowledge that obviously they are anonymised, those cases. It can be an emotive subject, it can be sensitive, so please feel free if you need to take a second away or pop any questions you've got in the chat. We will endeavour to answer those. Please make sure your microphones are off. I think Denise has already made sure that everybody possibly is muted. And thanks to Solihull Council and the Local Safeguarding Children's Partnership for hosting these events in terms of continuing to raise the awareness around exploitation and arranging for the webinars to take place. Utilise the chat function, as I've said, and we will endeavour to answer your questions at the end. So,
sorry to stop you, Sarah. Rebecca did have a hand up. She's put it down now, but I don't know whether, did you want to ask something, Rebecca?
No, sorry, I just clicked the wrong button. Sorry.
Oh, okay.
Okay.
No worries, don't worry.
Okay, so in terms of the learning outcomes, these were the learning outcomes that were advertised on the comms for the webinar, so you will have seen these anyway, but the main outcomes are to have an awareness and understanding around the term of exploitation, so we are going to touch upon that, have a clear understanding of the risk factors and the indicators, have an awareness of the role of health professionals in tackling exploitation, so we want to raise your awareness around that. You already know about it, I expect, but it's about reinforcing that notion. Acknowledgement of who are the health partners in responding to exploitation, and recognise and understand the importance of the multi-agency working in tackling exploitation, both children and adult victims. Share the thematic learning from local and national exploitation cases and recent audits as well. So the main focus is to heighten your understanding around the importance and the value of health professionals, their contributions to safeguarding victims of exploitation. And we hope that the webinar is informative and prompts you to reflect on the value and the importance of health in tackling exploitation across the Solihull area. We've noticed we've got a variety of different disciplines, different professionals, different individuals that have logged on to the webinar this afternoon. So thank you so much for sharing your time and taking the opportunity to participate today. As I say, I'm Sarah Clift, one of the Deputy Designate Safeguarding Nurses. I've been a paediatric nurse for 20 years. There is a little bit of background. Can you hear the background? Echoing, Joe.
Yeah, can people please make sure they've muted themselves?
Thank you. That's better. So as I say, paediatric nurse for 20 years. I was previously an emergency department nurse. I then went on to become a specialist community public health nurse, and then subsequently following my time as a specialist community public health nurse, I was a named nurse for safeguarding children in the Birmingham area, and since then I've been a deputy designate safeguarding nurse for adults and children for Birmingham and Solihull CCG. So I am very passionate about safeguarding, and particularly within the exploitation arena as well. So just value the opportunity to be able to share my experience with you, along with my colleagues' experience as well. So we're just going to touch upon this brief definition of what exploitation is. You've probably seen this before. I'm not going to read through it, so I'm just going to give you 20 seconds or so just to have a glance read through that. So obviously that's from the West Midlands Metropolitan Area definition, and that's what we refer to when we are explaining what exploitation is. And just really to focus your attention around this middle part, where individuals affected by exploitation can present into a wide range of health settings. So a wide range of health professionals can come into contact with victims of exploitation, both children and adult victims. Okay. And they may have been exploited even if the activity appears consensual. Quite often victims of exploitation don't see themselves as victims. they see themselves as giving consent. They don't see the wider picture of them being groomed, being exploited, and quite often not in a position to give consent either. It can occur face-to-face, but also through the use of technology. So moving on to the types of exploitation. So there are many different aspects within each of the types of exploitation. So there is child sexual exploitation, known as CSE, child criminal exploitation, known as CCE, gang violence, drug, knife crime, serious youth violence, adult sexual and criminal exploitation, and human trafficking and modern day slavery. It can be face-to-face, as I say, peer-to-peer or online, and it's usually extra-familial, although it's unusually via a family member, unusually has family links, but quite often we see siblings, particularly in younger children, adolescents. So one sibling might be what we call recruited or groomed into exploitation, and then sadly the other sibling can also go down that same avenue. So that's what we call, it can be links within families, but very rarely would it be outside of the family, inside of the family, where that would occur initially. Just got one clip that I wanted to share with you with regards to county lines, which we thought would be useful to share. So I'm just going to share that video now. There is me. Sorry. This technology, you think we'd all be used to it by now, wouldn't you?
Aisha's put in the chat, Sarah, that she's having problems. She can't hear anything.
Aisha, sometimes it's useful to log out and log back in. Quite often that's useful to be able to do that. Other than that, I'm afraid it might be an issue at your end if everybody else can hear, I'm afraid.
And just to say, this video is a few minutes long as well, isn't it, Sarah? So just bear with us. And
yeah, it's 9 minutes, but it does give you a good overview in terms of county lines. So we'll touch upon the additional information around county lines as well. Just bear with me. Can you see that screen now, Jo?
Yes, yeah.
Lovely.
Haven't got any volume for the video.
Hello.
Just bear with me then. Sorry, everybody.
It did just start then, sorry. My fault.
No, it's okay. Let's try again. Let me know if you can't hear. It should be on now, Jo.
In this video, we will examine how county lines work before exploring in greater detail the impact they have on children, vulnerable people, and society in general, before finally looking at how you can play your part in identifying and helping the police and other agencies bring down a county lines network, and who to report your concerns to. Let's start with a quick reminder of what county lines are from the Home Office definition. County lines is a term used to describe gangs or organised criminal networks involved in exporting illegal drugs into one or more importing areas within the UK, using dedicated mobile phone lines or other form of deal line. They are likely to exploit children and vulnerable adults to move and store the drugs and money, and they will often use coercion, control, intimidation, violence, including sexual violence, and weapons. It's important to note that the distance between these points is irrelevant. A county line can operate within force and local authority areas. It is the organisation and exploitation behind the drugs line which impacts society. How do county lines work? Criminals move into new areas with the intention of setting up a drug supply chain. They use middle tiers to recruit their drug mule workforce, most of whom are children or vulnerable adults. The UK's road and rail systems are used to transport drugs and children, with middle tiers arranging the transport for the mules, for example trains, hire cars, along with private hire vehicles being used to make the drop. Burner phones, that is, where a SIM card is not registered, are used to manage the drug deals between dealers and buyers. Bulk texts and private social media accounts are also used to arrange drops with drug clients, crack dens and members of the workforce who deliver the drugs to the user. Cash collected from drug drops is laundered through online bank accounts, casinos, corrupt businesses and even cryptocurrencies are used to grow the local market and extend a criminal's control of drug supply in an area to develop a foothold. The finance raised is used to buy more drugs from wholesale importers and again distributed via the new network, taking on more mules to replenish any that have been arrested and to grow their market. This completes the supply circle. Where a criminal gang starts to supply in areas away from their hometown to distance themselves from the criminal activity, they may lower their prices to gain a foothold or offer free drugs. Unwanted competition leads to serious violence between gangs. Children and vulnerable adult runners, their families and other innocent people are caught in the middle and often those most at risk of violence. The 6 key themes. So we know a little about how county lines work. Let's now explore some of the key themes touched on already. If any of these are familiar, please report your concerns as directed at the end of the video. Exploitation. Drug gangs exploit vulnerable adults and children, perhaps going through family breakdowns, with learning difficulties, living in care homes or trapped in poverty. They are often drawn in through social media and peers, exploiting their youth and insecurity. Criminals often look to groom and recruit children who are not known to the police or partner agencies, often referred to as clean skins. They are groomed with promises of money, friendship and status. Once drawn in, they are controlled with threats of violence and sexual abuse. They become traumatized and live in fear, paying for their keep through gifts from gangs, making them indebted and ultimately forced into debt bondage. Before you know it, they become modern slaves. Should you come across anyone who is afraid to talk about their day-to-day activities and appears withdrawn, ask yourself, could this person be part of a county line gang? Transportation. Drug gangs use all elements of the public transport system, sending the vulnerable and exploited in taxis, buses, coaches, trains, hire and even pool cars across towns, cities and the UK. The mules transport the cash and often secrete drugs into their rectum or vagina, plugging. If you hear of a vulnerable person or child making regular trips, ask yourself, could this person be exploited by a county line gang? Illicit finance. Criminal gangs cannot just bank their significant gains without raising suspicion. Instead, they use a number of money laundering techniques to disguise their takings. Having used mules to transport cash, it is laundered through corrupt shops, casinos, with online banking playing an ever-increasing role. If you hear of frequent cash deposits, ask yourself, could this be a sign of county lines activity? Violence. Drug gangs entering an area already supplied by an existing gang are highly likely to lower the price of their drugs, which, in turn, gives rise to an increase in serious knife and gun-related violence, turf wars, as dealers try to shut one another down. The targets are often children acting as drug runners. If you've noticed an increase in violence in your area, gang cultures, and an appearance of more weapons, then this could be a sign of a county line being developed. Drugs. All classes of drugs are traded, with homes of the vulnerable taken over as a base for illegal drug dealing, cuckooing. These people often become prisoners in their own home. If you know of vulnerable people, ask yourself if they could be a target for a county lines gang. Criminality. Overall, the existence of a county line in an area drives up crime, from theft and prostitution to pay for drugs to violent attacks on drug mules leading to deaths. Money is the driver, and ruthless gang leaders will exploit anyone to make it. If you've noticed an increase in general crime activity in your area, could this be down to county lines? How are the police responding? There are lots of ways that the police are responding to the threat of county lines. Many police forces have initiatives to tackle the transportation of drugs and cuckooing. Many arrests have been made and county lines have been closed down. The police are working with partners to investigate cases where vulnerable people have been exploited, and a lot of effort is being placed on trying to identify their exploiters. Police will make the best use of legislation where possible and, in fact, have successfully obtained civil orders to prohibit exploiters from certain activities that could lead to exploiting others. How can you help? Open your ears. E. Exploitation. Remember, county lines have a foundation built on exploitation. If we can work to protect the young, vulnerable, and those where their home has been taken over, cuckooed, we undermine this foundation. Those exploited are cheap to employ, disposable, and easily replaced if arrested. Signs of exploitation can be where the young or vulnerable go missing from an area. If we remove a drugs gang method of distributing drugs and collecting money, we bring the leaders out into the open and expose them to the risks should they wish to continue dealing. The key is A. Awareness. County lines don't just operate across borders. The term is a little misleading. Drug supply chains operate between towns, within counties, and even across cities. As a professional involved in healthcare, teaching, social services, policing, etc., you will more than likely come into contact with vulnerable people. Please make everyone you work with aware too. Look for signs of county lines. For example, did you know that a train ticket holds lots of information that can be of use to the police when investigating a county line? Maybe there are signs of unexpected wealth, new phones, clothes, etc. Possibly unexplained injuries, or unusual or increased levels of activity or antisocial behaviour in residential properties, which may indicate cuckooing. If you think something indicates a county line, then please, report it. If you recognise any of the topics outlined in the 6 key themes above, please contact the police or, to remain anonymous, Crime Stoppers without delay. You might be able to complete an online intelligence referral form if your local police force has one. Refer your concerns to someone who will take action to investigate them further. Remember, it's all about S, safeguarding the vulnerable. Keep this in mind at all times. It's the weakest in the county line structure who are exposed to the greatest risks and who need to be protected from coercion and violence. Who can I contact? If you suspect any county lines activity, dial 101 999 in an emergency. If on a train, contact the British Transport Police on 61016 or call Crime Stoppers on 0800 555 111. Where can I find out more? For further information, refer to Home Office web pages, the Knowledge Hub, and search County Lines. You'll need to sign up for a guest login if you don't already have one, or NC LCC. Also, view the Section 45 Defence and NRM SketchUp videos.
Okay, so I'm just going to unshare that video now. We just thought that National County Lines Coordination Centre video was very useful in terms of sort of highlighting the basics around county lines, and county lines is a prominent feature within exploitation. Obviously, county lines affects children, young people, adults alike. So can we just make sure everybody's got their microphones on mute, please? We have got a little bit of background noise, and I think that maybe affects people hearing the videos or the presentation. It's going to share the presentation again. Okay, I have got another video regarding modern slavery. So what I'm going to do with regards to that one, it's similar to the county lines one, but focuses on human trafficking as well. So after my part of presenting today, I will upload that link into the chat for you, so you've got access to that as well. It's just an additional resource video if you wanted to look at that as well. So moving on to the exploitation indicators and risk factors. So as you can see, that list there is quite extensive. I don't really like busy slides, but quite often we need to get the impact in terms of, you know, the risk factors are vast. But what I want to do is highlight that these lists aren't exhaustive. Okay, so there are many other risk factors and indicators that might be present that you would maybe notice or that would be present, and there may be multiple risk factors present when you are dealing with a child or young person or adult in terms of exploitation. However, there might just be one of these present, and then that would be your responsibility as a professional, as an individual, to utilise your inquisitive inquiry. So utilise your questioning, your exploration, your professional curiosity in terms of ascertaining, are there any unknown risk factors that perhaps aren't you know, staring you in the face, that they're not visible. Okay, is there something else that you're missing? So it might be that you've got a young person, for instance, who's got poor school attendance, so it's around exploring additional risk factors or additional issues that might be present in that child's life, and it might be that by doing that you are then unfolding a greater picture, that you are able to acknowledge and identify other risk factors that are there. So abuse in the home, mental health issues, that includes depression, eating disorders, self-harming. These are just some of them. So substance misuse, homelessness, history of offending, particularly with young people, adolescents, but also with adults. School exclusion, poor school attendance and truancy, mentioned earlier on. Challenging or changing behaviours, sexual health impact, repeated terminations of pregnancies, that's TOPs, sexually transmitted infections, concealed pregnancies, multiple pregnancies. Access to emergency contraception might be something that would raise alarm bells if it's repeated access for requests for more contraception, emergency contraception. Gynae concerns, so repeat UTIs, urinary tract infections, and their loved ones, particularly parents or carers, might express concerns around that person's behaviour. A&E attendances, so professionals within health organisations may get notifications from A&Es that a child, young person or adult has attended there, perhaps with a physical injury. Knife wounds, assaults, they may have been arrested, found with drugs or weapons, they may have concealed articles, SIM cards, drugs, vaginally and anally. That's known as internal concealment or plugging. They may have unexplained injuries that they cannot explain to you and that you don't know how they occurred. They may be in possession of unexplained gifts, money, goods from unknown people. They may become quite secretive. Have a change in their appearance. It might be that they were normally very well presented, took care in their appearance, and have suddenly started to look a little bit dishevelled, a little bit unkempt. It could be in the reverse as well. It could be that suddenly they are dressing very, very differently in expensive clothes. They might appear nervous when you speak to them, or scared and evasive. They might not want to answer any questions. Quite often we get that with victims of exploitation, that they don't want to comply. They're evasive. They don't want to answer questions. There may be missing episodes, so they may go missing for a period of time, a number of days. We don't know their whereabouts at that time, and then suddenly they return home. And adults and children who are not allowed to be seen alone. So quite often we get individuals that attend appointments but are always accompanied. They never get the opportunity to speak alone. So that's really important that we give them that opportunity. But to be mindful that actually those groomers may actually be listening into conversations as well. So we need to be mindful of that. And I always say to health professionals, particularly that I'm working with, is give them the opportunity to write. Give them a pen and paper. If their mobile phone is turned on, so they're on loudspeaker, so that perpetrator, that offender, that groomer can hear what's being said, that we give them the opportunity to actually write something down, because we have on occasions in primary care had a patient that's actually requested and signed in front of the GP that they wanted pen and paper, and then they've been able to write the issue, the problem, their worries, the risk onto that paper, so that person was listening then couldn't hear what was being said. It might be that they've got poor self-care, post-traumatic stress disorder. We've mentioned the concealed items and the plugging. But as I say, that list isn't exhaustive. Refer to the Solihull All-Age Exploitation Screening Tool. We will add that into the chat later on as well, so you will have direct access to that resource that you can use in practice. Again, there are additional indicators and risk factors that are on there that you need to be aware of. And when making a referral, make sure you're including the risk factors on that referral so it's very clear what your concerns are. So these are additional risk factors and things that increase vulnerability in relation to the victims of exploitation. So it might be that they're new to country, that they don't have any support, they don't have any access to public funds, so no recourse to public funds. They're unaccompanied asylum seekers, isolated. They might be dependent on drugs or alcohol. And there may well be a language barrier in terms of human trafficking, in terms of modern day slavery. It might be that they don't speak English, they don't have that means to communicate that risk. They may have mental health issues, homeless, as we mentioned earlier. And it might be that they're not attending appointments, they might not attend medical appointments or otherwise. They might not even be GP registered. They might be always living in the UK in Solihull, but they might not have a GP, and that increases vulnerability. There may be past trauma and abuse, so adverse childhood experiences, ACEs. They may have gone through previous trauma, which then increases their vulnerability later on in life. They may have emotional and psychological impacts from that past trauma or from the current situation that they're in terms of exploitation. They may have a learning disability, they may have special educational needs or disability. Children in care are increasingly vulnerable to being exploited, and we know that through both the Birmingham and Solihull health economy, and that we have children in residential homes and in foster care that are victims of exploitation or have been victims of exploitation. There may well be previous children's services involvement. There may be vulnerabilities in their home life, which makes them increasingly vulnerable to exploitation. And they may be living in a chaotic household where there's domestic abuse, for instance, neglect, emotional abuse, physical abuse, and that often makes them vulnerable in terms of exploiters and groomers that then target those vulnerable children, young people, adults, because they have no one else in their lives. So they actually feel very supported by that perpetrator. They feel very wanted, very needed, and they have that sense of attachment to them because they're showing an interest in their life at that point. And there may well be exposure to violence. There may be gang affiliation in terms of the exploitation. And they may be friends with individuals who are exploited. It could be peer-on-peer recruitment in terms of the exploitation. And they may lack friends from the same age group, which then they look up to older perpetrators in terms of the exploitation. They feel wanted. But obviously organised crime gangs, they recruit and they see these vulnerable individuals and they then hence become a target. So what I want you to do at this point is just for a moment, have a think about in the role that you are currently working in, or the individual, maybe you're a foster carer or you know, a professional in education, for instance. Have a think about in the workplace that you are currently working in is who are your health partners? What contact do you have with them? Do you liaise regularly with them? Do you liaise with them at all? Do you include them in the partner agency working that you undertake? Do you even know who they are? So when we are routinely thinking of health, who are we thinking about? So have a little think about that and maybe pop it in the chat if you want to. Joe, Anjana, you can shout that out if people put anything in the chat.
Yeah, okay.
But who are your basic health partners in the roles that you undertake? For instance, it could be GPs, or it could be community psychiatric nurses. Is there anything in the chat at all, Joe?
Not yet, I'm waiting.
Are we waiting patiently?
Don't be shy, everybody.
No, we don't bite.
Okay, Tamina said health visitors. That's brilliant. Good example.
Any others? No?
Community LD nurses, Michelle says. GP, fabulous, all good stuff. Yeah.
Nurses, solar, school nurse.
Brilliant, that's fabulous. So absolutely, they are the core health professionals that we automatically think about when we're thinking of health partners. However, I want to sort of expand your thinking and think much wider than the basic health professionals that we normally deal with. And we need greater acknowledgement and consideration for the inclusion of those additional wider health partners. Okay, so the next slide is I just want to draw your attention to the vast amount of health partners that you can consider in your daily practice. So if you look at the green circles around the middle, they are all additional multi-agency partners. Okay, so you've got children's social care, adult social care, youth offending service. Now I know within youth offending service we have community psychiatric nurses as well, but fundamentally the youth offending service is a partner agency outside of health on its own. Interpreting services, charities, just moving around this bottom part, police, border agency and home office, housing, counselling, trauma service, education. Now they're just obviously the ones that we've included as a basic, okay? So if you go around the outside, the blue circles that we've included, that displays the vast arena of health, okay? So these are your health partners, and you can see that it's inclusive of so many different areas of health. So if we start at the top, we've got maternity services. So within maternity, you've got safeguarding midwives, you've got antenatal, obviously postnatal midwives, domestic abuse midwives in terms of safeguarding. So that's obviously, you know, just maternity services on its own, but that obviously filters out to different arenas, different parts of maternity in terms of safeguarding. Mental health services, both in the community and acute settings. Mountain Healthcare, so they coordinate child protection medicals and deal with victims in custody. Primary care walk-in centres, GPs, practice nurses, dentists, opticians. So these are all the professionals, the health partners that you can be liaising with to share information around vulnerable victims of exploitation, both children's and adults. Drug and alcohol services, community health teams, community nurses, paediatricians in hospitals and in the community, specialist nursing teams, diabetes nurse specialists, learning disability nurses, safeguarding nurses. So in my arena, in Joe's arena, we've got children in care nurses, designate safeguarding nurses, named nurses, exploitation nurses, sexual health services, public health nurses. So when we talk about public health nurses, we mentioned before in the chat around health visitors, district nurses, school health nurses. And then you've got ambulance services. So ambulance services are vital in terms of sharing information around call outs, victims that they've dealt with in terms of injuries, taking children, young people, adults, victims of exploitation where they may have sustained an injury, they may have been stabbed, shot, you know, they then take them to A&E, where they then are dealt with, and charitable organisations in terms of health, such as Red Thread, for instance, are based in the hospitals, that they would then liaise with other health agencies. And you've got the acute health settings, as I said, emergency departments, hospitals, consultants, and the sexual assault referral centre. But what I wanted to highlight is that those health partners don't sit in silo, they don't sit in isolation. So imagine you have a ring that then joins, a line that joins all of these blue circles together, because each of these health agencies, not only do they speak to each other in terms of sharing information around victims of exploitation, but we also share with everybody else in terms of partner agencies. So actually the lines of communication across health, but they also go amongst other organisations as well, so that it's all joined up. And I think that's what we wanted to highlight, is that actually just by you sharing information, for instance, with the GP, is vital in terms of that GP then liaising with the health visitor that's linked to their practice, with the midwives that are linked to that pregnant mum, with mental health services where the mother accesses mental health services, with safeguarding children's nurses if there's a strategy discussion, for instance. So it's all joined up. So I think we just wanted to highlight that actually the health partners are actually vast, and we would like consideration, obviously, for you to acknowledge them and actually share information with them in terms of exploitation where you can, both in the interests of the victim, but also in the interests of information sharing. So I'm going to pass you over now to my colleague Joe. Joe, I'll allow you to let you introduce yourself to everybody, and I'll go on mute.
Hello again, everybody. Yes, I'm Jo Leci, and I'm named Nurse for Safeguarding Adults for the Birmingham Solihull Mental Health Trust. I'm a mental health nurse by background, and I offered to share a case study with you today. Obviously in Solihull we're thinking about all age exploitation, and this case relates to an adult who was a victim of modern slavery. Some of you may have heard the case before, so I do apologise, but it's always worth sort of thinking about it again, I'm sure, because there's some really key points that come out of this case study. Sarah, I don't know whether, are you going to share the case study on the screen for me? That would be really helpful. It's just a one-page summary, but I'm going to talk around it a bit more to give you a bit more detail. I think that this case in particular is really useful to think about because it highlights the number of health organisations and teams that were involved with this particular lady. And also it draws on a lot of the things that Sarah's mentioned in her previous slide. So in terms of the importance of sharing information and some of the recognising some of the indicators and some of the additional risks and vulnerabilities that you might see with a victim. So
can you see that on the screen?
I can, yes, thank
Okay.
you. Yeah, this is a case that I actually became involved in myself, and I became aware of it because within our organisation, a member of the psychiatric liaison service, who were based in the A&E department at a local acute hospital, they'd recognised that there were some indicators around modern day slavery, and they'd completed what we call an Eclipse incident form. So that if there's any element of safeguarding, that comes through to the safeguarding team. And because people had shared that information, that's how I became aware. So as Sarah was saying, it's so important to share information not only with your partner agencies, but also within your own agency so that you can escalate any concerns. So this particular young lady, she was 25 years of age. She'd come from Poland originally, and she'd attended the local accident and emergency department, and staff were sort of immediately concerned really for her because she was acting quite bizarrely, quite strangely. She seemed to be hallucinating, and she was talking about, she had some paranoid ideas about her boyfriend. But what was also of concern was that staff could see that she'd got bruises and bite marks to her arms. So obviously there was something that wasn't quite right. She did say that her boyfriend had been giving her drugs and alcohol, and that was, she said, to make her do what he wanted. She thought that he was putting drugs into her drink, and also she described that she'd been getting prescribed medication for mental health, but we weren't quite sure at that point where the medication was coming from, because we noted that she wasn't registered with a GP in this country, even though she'd been here for some time. So again, whether she was prevented from registering, we're not really sure, but I guess it just highlights how important the GP is in terms of being the gatekeeper to other sort of services, really. So I think she'd sort of gone under the radar a bit. The Acute Trust really worked very closely with the Mental Health Trust, and an agreement was put in place to keep her in over the weekend on the ward within the Acute Trust. At that point, she wasn't sort of deemed to be sort of sectionable under the Mental Health Act. I think as the substances were starting to wear off, she appeared to have capacity and agreed to stay on the ward, and a referral was made to Hope for Justice, and Hope for Justice were going to come and see her on the Monday morning at the hospital. Unfortunately, she absconded from the ward over the weekend. This was reported to the police. So she was reported as a missing person because she was obviously vulnerable for the reasons that I've said. She was discovered 3 days later, semi-naked and attempting to wade into a local reservoir. The police picked her up, brought her back to hospital, and she was assessed under the Mental Health Act, and at that point she was brought in to one of our acute units under a section of the Mental Health Act. And she remained there for a couple of months until her sort of mental health stabilised, and you know, all throughout there were lots of organisations involved. We had support from charitable organisations. Women's Aid were really helpful. The consultant on the ward actually liaised with the lady's consultant psychiatrist back in Poland, and Christina had said all along that what she wanted was to return back to Poland. She'd got a 5-year-old son that was over there, and so I guess that really demonstrates making safeguarding personal as well, because what she wanted, the outcomes that she wanted, was really sort of listened to all the way through. And in this situation, it was a happy ending as far as we know. The Polish Society actually funded Christina's return to Poland, and staff from the mental health unit took her to the airport and actually saw her through the gates and onto the aeroplane. And she hasn't been back to our services since. She was provided with a number of organisations back in Poland that could also support her. So I felt it was a really good example of, you know, how things, a positive example really of how things can work out. But it just shows the number of agencies all along Christina's journey that were involved and supported her to get the outcomes that she wanted. And I think it's, you know, it's great that staff recognise those initial indicators, so they could get in early and provide that early help. So some of the key learning from this is, as I say, the early recognition and the response. I think professionals were definitely curious and they asked more questions, and you know, there was ongoing assessment and interventions to support Christina. She was provided a safe space. Obviously, she was listened to and sort of seen on her own. There was lots of joint working and communication between agencies, and there were professional meetings as well, which supported the progress. And I think it's really important as well to know what specialist services are out there around exploitation and modern day slavery. I mentioned Hope for Justice and Women's Aid. And I think, you know, without their support, this would have been much more difficult, you know. She was somebody that had a past trauma, and she had got a number of adverse childhood experiences. So again, that links in with what Sarah was saying about vulnerabilities. There was definitely that in Christina's background. She'd definitely got those extra vulnerabilities. What else? Yeah, mentioned MSP. So again, it's, I guess MSP could be seen as the equivalent of hearing, you know, the voice of the child. So it's really important to consider what the person wants and the outcomes they want, but also to make sure that that is recorded and demonstrated, because I think it's something that sometimes it's quite difficult, isn't it, to actually demonstrate that we've done that. So that's a plea to everybody out there to sort of record that and make sure we've got that right for people. And again, some of the key learning is about the mandatory reporting. So in this case, it was obviously reported to the police. An adult safeguarding referral was made to the local authority as well. And from there, a referral to the national referral mechanism. I think in terms of improving practice, as professionals, we need to consider the possibility of coercive control, and I think that was very much prevalent in Christina's relationship with the boyfriend. So again, any learning around that would be really useful. That professional curiosity, sort of digging a bit deeper, sharing information with other agencies or asking other agencies for information was really helpful. And then I know Denise has put something in the chat about the all-age exploitation strategy, and we've got the screening tool now as well, haven't we, that would be, you know, would have been really useful at the time. When this case came to my attention, it wasn't in place, but yeah, I just draw everybody's attention to that now. And a reminder that the screening tool can be used. It's a working tool, so you can use it more than once as well. So you might need to repeat that sort of further on down the line. We've also got the Home Office guidance as well, and there's links there on the slide to that for anybody that's interested. Will the slides be shared, Sarah, with?
They will.
With the, yeah, okay.
Yeah, so the slides will be shared, and also we'll pop additional links in at the break in the chat so people can save those and open them as they're having a coffee, or afterwards it'll be available to them.
So I really hope that that sort of demonstrates and pulls together some of the information that was in the slides that Sarah showed earlier. And I think another thing that I didn't perhaps mention was the trio of vulnerabilities. So in this situation, we'd got mental health, substance use and domestic violence, domestic abuse as well. So again, it was quite a high risk really. I don't know if anybody had any questions or if we've got time for questions, but maybe if there's anything you want to put in the chat. Okay, thank you.
Thanks, Denise. Thank you. Thanks, Joe. It really highlights the reliance of professionals working together, I think, and it also highlights the mental health clinicians with a lead in the coordinated response in that particular case in relation to safeguarding that lady. And the liaison with partner agencies is absolutely vital, particularly including health, because, as I say, quite often health are the gatekeepers in terms of contact with these victims of exploitation. So I think there was just one other case study, I think, at this point I would like to share with you. Let me just go into the presentation again. And I just wanted to draw your attention to this case that I've worked on previously, and just to have a think about as I'm talking, what agencies do you think might be involved from health with this young person? So 14-year-old victim of exploitation, child criminal exploitation, particularly county lines. He was a gang affiliated individual where there were internal concealment, issues around internal concealment, episodes of internal concealment, plugging of the drugs whilst he was transporting them across the city and into other parts of the UK on the train. His father was in prison. He lived with his mum and two younger siblings who were both school aged. He lived in the inner city part of Solihull, unstable home life, poor school attendance. He had special educational needs. His mother had refused early help that was offered, and he had ADHD, behavioural issues, previously known to Children's Services and was previously on a child protection plan for neglect, history of domestic abuse in the family home and really poor home conditions. There was a history of criminality with the 14-year-old, particularly theft, assault, robbery as he got older, and he was removed from his mother's care previously. He was open to child and adolescent mental health services, which subsequently he did not attend those appointments that were sent to him, sent to his mum at that point. Eventually was excluded from school. History around drugs, money, there were markers for weapons, arrests for county lines, repeated arrests for county lines, repeated episodes of missing, and there was an NRM status in 2018, so we'll come on to NRM shortly to explore that a little bit more. And he was immersed in criminality. So it was an extremely complex case. Eventually he was placed in secure accommodation in view of safeguarding him, accessing support, and eventually was placed in foster care in terms of safeguarding him and removing him from that situation. Eventually accessing education, but there were still difficulties along the way, and there continues to be difficulties. But he was reliant on support from partner agencies, both the police, education, children's services, and health services. So having spoken about that scenario, I just wanted to highlight all of these professionals that were involved with this 14-year-old. So again, referring to the blue are the health professionals that were involved, and all of which join up and communicate with each other and communicate with other partner agencies as well. But it's just to highlight the heavy reliance that we have on health agencies in terms of protecting victims of exploitation in order to identify risk and to safeguard them in the long term and the short term. So it's just really for you to acknowledge, obviously, the complexities around safeguarding, particularly, you know, the health professionals that are involved. So that was just my brief overview of a case that I was involved in, and you can see, you know, there's a number of health professionals that are involved there, and this case sadly went on for many years. So he would be referred in and out of mental health services. He was in and out of care, so the children in care team were involved in terms of children in care nurses. Had appointments with paediatricians. The GP was the gatekeeper in terms of having that information sent to them in terms of current risk, ongoing issues, that they would then share that information with other partner agencies. But there's a heavy reliance on partner agencies such as education, police, youth offending, children's social workers, you know, particularly with adult cases as well, there's a heavy reliance on those agencies sharing that information with health. So we're reliant on you as partner agencies in sharing that information with us in order for us to continue to safeguard that person, but also to be aware of the risk in that person's life at that point, because that risk, that notification of risk, will prompt a reassessment of health needs. So without that information, we are unable to obviously at that point reassess the health needs. Any questions with regards to that case? No, I'm assuming there's nothing in the chat, Jo, so I'm going to hand over to Anjana now to share her case.
Hi, I'm Anjana Ranjit. I'm the named GP for safeguarding at the BSol CCG, and in my other life, I work as a GP in Bartley Green. So in the theme, keeping with the theme of information sharing, I'm going to present a case which has occurred in primary care. As Sarah was saying, yes, GPs are the gatekeepers, and in primary care, our responsibility would be to spot the signs and then provide as much early intervention as we can, and then signpost and refer people, as well as information sharing with other agencies. So this is a case of a 15-year-old girl with non-ADHD, which is a neurodiverse condition. And the parents consult the GP requesting mental health assessment regarding her moods. She was having self-harm attempts and suicidal ideation, and they were requesting a private referral to a psychiatrist. She had also presented to the GP with heavy menstrual bleeding a couple of weeks back. So each appointment was dealt with in its own right. The heavy menstrual bleeding, she was signposted to the medication that's needed to slow down the bleeding, and she was also referred to secondary care for assessment, to the mental health team for assessment regarding her moods. But unbeknown to the GP, what the GP didn't know at the time when she consulted, can we have the next slide, please, Sarah? The GP was completely unaware about the safeguarding risks that were already known. The GP was unaware that she was under the social services and police. She had school were concerned about her mood, and she had also inquired about sexually transmitted infection check at some point. She was missing often, and the GP had no realization of any of this happening. There were no letters to the GP. She had also been through a MACE meeting, but again, no reports were sent to the GP, and the GP wasn't requested to contribute to the MACE meeting either. So the question would be, would it have been different? Would it have been a different approach? Were the GP aware of all these concerns? Well, it shouldn't be in an ideal world, but sometimes in a busy consultation, sometimes this can prompt us to, the knowledge about the circumstances can prompt us to think about this and ask questions and signpost and help and support as much as we can in the consultation. This girl had so many vulnerabilities that GP was completely unaware about. Sometimes in primary care, as GPs, we have presentations like a consultation request, which might be an emergency consultation request. This might be just for 5 minutes at a time. So if there is knowledge about the underlying vulnerabilities, yes, we need to be professionally curious in all consultations, but sometimes it can prompt the GP, however busy the consultation is, into asking and supporting the young person or an adult at that point. So that's the message I wanted to convey. And certainly, as we all know, multi-agency coordinated response, we should all work together to support early help and management. Again, yes, if you're professionally curious and asking questions, if we have a prior knowledge, we could reduce re-traumatization and hence minimize risk as well. Also, it would allow the GP to make appropriate and timely management and interventions. So they would think about speaking to the child if mom and dad were calling for help, what has been done about it, what's happening in the home. So encouraging them to think about it more, however busy the consultation might be. So it is in the theme of information sharing, and sometimes GPs are not aware of what's happening within the family. Any questions on the case at all? Okay, the next slide is about how to make contact with health professionals. So as Sarah said, there are so many of us. There's a wide variety of people within primary care and within the secondary care in terms of the healthcare sector. I'm going to talk more about how to make contact with health professionals within what we call as primary care, which is the community-based team. So yes, GPs are the gatekeepers of information, and they would have any sort of letters come to them, whatever services are involved with the patient. So it would be good if you need any sort of information on any other agencies or disciplines involved with the child or young person or the adult, you could contact the GP and they could signpost you and let you know what other services are involved. Well, saying that, yes, sometimes it's very difficult to contact the GP. So the best way of contacting a GP would be through their generic email, if you can find it on the website. Most of the GP practices now have a website of their own, and that should tell you about the generic email that's probably monitored every day. So you could send a request if it's non-urgent to the generic email. You could also ring the GP reception. Sometimes the phone lines you can be 36 on the waiting list sometimes. But if it's really important and you need an immediate answer, you can ring the reception. But sometimes, you might not be put to the GP straight away because GPs would be in consultations from 9 till 12:30 in the morning and from 2 till 6:30 in the afternoons. So you can leave a message with the reception. If you leave your mobile number and any other contacts that you have, the GPs will get back to you. For a school-age child, the school health team, the local school health team should be able to give you more information. And again, if sometimes we rely on them because we wouldn't know the schools which the children go to. So in which case we can contact them and they can signpost you to which school the child is registered under. Also, for the under 5s, the health visitors are a very good source of information because they do share systems there. I think it's called the Rio system, which they share with other agencies. So they would have information on the children under 5, and sometimes their siblings as well that you can share with. And as GPs, we generally have regular meetings, at least 3 monthly meetings with health visitors in terms of people, our children who we do have concerns with. Next slide, please, Sarah. The next 2 slides, one is on reachable moments and the other one is on NRM, which we talked about to a certain extent anyway. So in terms of reachable moments, from our point of view, from a health point of view, most people would have contact with health for one reason or another at some point. So it's about capitalizing on this opportunity and making every contact count in terms of assessing the vulnerabilities and the safeguarding risks that people have. But what we call as a reachable moment is when there has been a change in circumstances for the child, when there has been a dramatic deterioration in the child's behavior, when there's a risk of exclusion from school, or when they have been through an assault or an injury, or when arrested, or sometimes at school exclusion points. That's when they probably might be very reachable. And we need to capitalize on this and make sure that we can do everything, early help and support as much as we can. In terms of making every contact count, yes, as I discussed before, we are trying to promote this as much as we can within healthcare. So anytime a child or a young person or an adult presents, we should be inquiring, we should be exercising professional curiosity and trying to gain the lived experience of the person or the child in front of us. Next slide, please, Sarah. In terms of NRM, I'm sure all of you are probably very aware of it, but we just wanted to make sure that from the NRM point of view, any person who would be a victim, who is suspected or is a victim of modern slavery, it's best to be referred into the NRM. And it's the first responders who make the referral. And the referral, unfortunately, health is not a first responder, and we would have to refer into social services for people to be referred into NRM. But there are lots of benefits in terms of providing help with accommodation and legal benefits and that kind of thing. So we just wanted to reinforce the fact that, yes, we do need to do an NRM referral, but health cannot do an NRM referral, and we might need the help of other agencies to refer into NRM. Is there another slide after this, Sarah? Yeah, so those are the agencies that can do the those who are the designated first responder organizations, but unfortunately health is not one of them. I think you have a short clip, do we?
We have got an NRM clip. I'm going to pop that in the chat for people to access, and they can obviously look into that after the training. What we're going to do now is we're just going to break for 5 minutes. So we'll have a 5-minute coffee break until just after 10 past. So if you want to go and grab a drink, and we'll pop back and carry on with the remaining part of the presentation. Thank you, everybody. Thank you, Anjana, for that.
Sarah, just before we go, I just wanted to bring everybody's attention to some of the things that have been put in the chat. Rachel's very kindly explained what the acronym MACE is, Multi-Agency Adult Child Exploitation Meeting, because I know we've mentioned that a couple of times. Thank you, Rachel. And Denise has mentioned some trauma-informed training, and we also talked about ACEs, didn't we? Adverse childhood experience. So Denise, thank you very much for putting that into the chat as well.
And that's great. So if we break for 10 minutes, in the break, I'll actually pop in the links for the NRM clip. I'll pop in the YouTube clip for modern day slavery, and I'll also put the link in for the Solihull all age exploitation screening tool. That's a mouthful, sorry. We'll pop that in the chat as well. So if you want to join us back in about 5 minutes promptly, and then we can complete the last part of the webinar and let you go and get a drink. Thank you. I'll just share the presentation, Joe, ready for you.
Thank you. Before I start with the next slides, I just wanted to bring to everybody's attention a comment that I think Rachel's put into the chat about the majority of people in Solihull that are victims of modern slavery and trafficking in the borough are UK citizens and residents. Obviously, the case that I shared was a lady from Poland, but I think you previously mentioned, Sarah, that trafficking doesn't just occur across international borders, but it can be within sort of counties within the same within the UK, can't it? So yeah, just to highlight that so that people are reminded, really. Okay. We've got everybody back, hopefully. So the next few slides that Sarah's asked me to talk through is about the role of health in tackling exploitation and what health professionals can contribute when supporting victims and other partner agencies. Can you move on? Thank you. Thanks, Sarah. So the first thing that we've got is identifying exploitation signs and indicators. And as we saw in the case study that I went through with you earlier, that was something that was picked up quite early on, really. I mean, there were some very obvious signs because the victim was telling us that she had been a victim of sexual exploitation, and there were also the physical marks, the bites and the bruises that gave us some indication. Now, within my own organisation, we've been doing quite a bit of work around this. We've set up an exploitation reduction task and finish group, and as part of that group, we've put together a 7-minute briefing. And we've also put together a checklist to help staff within the organisation. And that sort of covers indicators and exploitation signs as well within that. So I don't know what other organisations are doing, but maybe that's something to think about for yourselves. Health as well, in terms of building up professional relationships with individuals. Often we're in a really, good place to be able to do that. In the going back to the case scenario again that I mentioned earlier, the Christina case, she was seen in A&E. Often there's not a great deal of time within A&E, but I guess it's about identifying those risks early, making sure every contact counts, and referring on to other health agencies and partner agencies that can support. Health also obviously assess risk. That's something that hopefully we're quite good at and is sort of dynamic and ongoing. I guess we could all get better at early intervention and early help. And as I say, part of that is identifying the signs and indicators in the first place. But if we can get in there early and provide support and provide specialist support, then that's going to be much better an outcome for the victim. I think it's really important, isn't it, that we're able to signpost and refer the victim when they're at risk of harm. And so it's about knowing what organisations are out there, specialist organisations, charitable organisations like St Giles Trust, the Red Thread, who've been brilliant. They've come and spoken to us at our Exploitation Task and Finish group. We've got the Salvation Army and Bernardo's. But it's also about knowing when to refer to adult social care and children's services and the police, particularly as we heard in reference to the national referral mechanism, because so children's services, adult services and the police are first responders in those situations, and health isn't at the moment in terms of NRM. So again, multi-agency working is key, and that information sharing. And as we know, one of the key things to come out of serious case reviews, domestic homicide reviews, CSPRs and SARs is that information sharing was lacking, and that's a consistent theme that we've had. But particularly with exploitation, we can see from the case studies we've heard how important that information sharing is. And just another plug for GPs, please do let GPs know, and that they are, really crucial, aren't they, in terms of health services for everybody. So we do need to be liaising with other health staff and non-health partners, for example, education, schools, your designated safeguarding leads within schools and colleges, and any other professionals involved. So housing, again, is a key organisation that you need to be sort of liaising with. And I'm sorry, because the list is endless. There's quite a lot of organisations, isn't it, that we do need to be sharing with, professionals that are working with the person at risk. And again, a plug for MACE, the multi-agency adult and child exploitation meetings. We do need an invite for health, please. It's really important that we're there and we can contribute and provide support and information. I think this, so what is the role of health in tackling exploitation? Well, I guess, our role is quite big, really, as we've seen. Health are able to attend strategy meetings, MACE meetings or professional meetings. We can carry out lateral checks to see if people are known to us and whether we've got any information relating to exploitation on that person or persons. Information sharing, recognising and supporting vulnerable children and adults at risk of exploitation. We can provide mental health support, drug and alcohol services as well. Health can provide sexual health assessment and support, midwifery support and school health support, emotional wellbeing support. We can provide a safeguarding response. So we might be able to put things in place that can support a person, young person or child or adult. We might be able to put some safeguarding responses in place. We can assess physical health needs and provide trauma-informed practice as well, because as Sarah said, many people have previous trauma and have vulnerabilities, and we mentioned ACEs as well, didn't we? Childhood sort of adverse childhood experiences. So we can signpost, health can signpost to partner agencies, other health agencies, and we can liaise. And we also share information with the local Safeguarding Children's Partnership and Safeguarding Adults Board for data collection. We've been involved with audits, and I know that there was one recently in Solihull around exploitation, where partner agencies and health reviewed 20 cases, and we provided information around the audit, exploitation audit for that. So, and we also contribute to safeguarding adult reviews, CSPRs, and domestic homicide reviews where exploitation is a theme. So again, I don't suppose that list is exhaustive. I think there's actually another slide, isn't there, Sarah, that continues. So just to say, really, health features at every stage. We're often the first point of contact, and A&E is a prime example of that. We are an essential part of safeguarding conversations, and it's important that health input is included in any case of exploitation. We should be seen as equal partners, and we're fundamental in the coordinated response in relation to safeguarding and exploitation. We've said before that the GPs are gatekeepers. In the Christina case, she didn't have a GP, so that was one of our priorities, to get her registered. And health practitioners are a major stakeholder in any exploitation case that we're working with. And we're critical and have a vital role to safeguard victims and their families.
Thanks, Jo. Okay, just move on to the next part. Bit of a delay in my there we go. So yeah, this next slide really just evaluates and looks at the barriers to successful multi-agency working. So I'm sure across you know, the disciplines that are present today and the professionals that are here, that we've all experienced barriers when it comes to multi-agency working. And it might, you know, in terms of exploitation, it might be to do with you know, any other type of safeguarding issue. But these are just some of the barriers that you might have come across and to be mindful of. So there might be language barriers in terms of the victims. So in terms of sharing relevant information, it might be very difficult to get that information from the victims in order to share it. So it's about making sure that we have interpreters there, independent interpreters. We don't rely on the victim's friends. They maybe not be friends. They could be part of the gang, the organised crime gang that have recruited, have groomed that victim. We don't rely on friends, for instance. We don't rely on family in terms of interpreting. Make sure we have somebody independent that's there to interpret for that victim in terms of safeguarding. Language matters. So I've got a document that I will share, a recent document that was launched this year in terms of language. The importance of speaking to the victim in a language that they understand, that we don't use medical jargon, jargon within your own organisations, and particularly within documentation. When dealing with children particularly, we need to make sure that they have a sense of understanding around the conversations that we are having with them, and vulnerable adults that might potentially have a learning difficulty, you know, potential capacity issues. So we need to make sure the language we are using with victims is appropriate and they're able to understand it. Other professionals may not see the value of health professionals. So it might be that they say, you know, well, we don't need to share that information. Every bit of information is valuable to share, and it needs to be proportionate in terms of the information sharing that we're undertaking. Agencies sometimes work alone, so in silo, we've mentioned that's a challenge sometimes, and they may not have shared understanding or a shared language or appreciation for health's input, and different organisational cultures may feel that, you know, health aren't a valued partner, and we hope that isn't the case. It's very rare that we come across that, but we need to make sure that is instilled across partner agencies, that health are a valuable profession to offer input. There may be a lack of understanding in terms of the risk factors relating to exploitation, trafficking, modern day slavery. So it might be that some members of staff in organisations, perhaps, you know, staff maybe haven't had extensive training around exploitation. They're not familiar with the risks, they're not familiar with the term exploitation and what that means. It might be a training issue, but they might have a lack of understanding, and that can present as a barrier in terms of working with partners. There might be an issue around time, staffing capacity, lack of understanding from agencies in relation to threshold guidance in the local area. So for instance, across Birmingham and Solihull, we have 2 different threshold documents, 2 different exploitation screening tools. Birmingham have a child only screening tool, whereas Solihull have a child and adult screening tool. So it's around as professionals that we familiarise ourselves with the threshold guidance and the screening tools that are relevant to the area in which you're working with, and that prevents barriers occurring and difficulties and challenges. There may be workload pressures that prevent people from sharing information. That's a barrier. And again, lack of partner agency working, and we don't have one system, sadly, that we all work from. You know, police, health, children's services, adult services, education, we all don't work from the same system, which can present as a barrier. And as I said, I mentioned around the lack of training and understanding, and poor multi-agency working, you know, sadly is repeatedly reflected in serious case reviews, child safeguarding practice reviews, safeguarding adults reviews and domestic homicide reviews as a repeated learning point. So we want to avoid that repetition, and if we can avoid it just by raising the awareness around the importance of multi-agency working, we hope that we don't have those future challenges, you know, in future serious case reviews. That's not a learning point for future cases, but you know, we just need to have a shared understanding that we need to share information and communicate, because ultimately that only benefits the victim, whether that be a child, a young person or an adult. But it is a professional challenge, and we appreciate sometimes that these barriers are present. One thing that we did want to draw your attention to and highlight was that a recent audit within Solihull around the all-age exploitation audit, the findings around that and the learning. So these were the points that were identified that we thought was quite useful to share, because it's relevant to all agencies, all partners, that we need to make sure that we instill a sense of professional curiosity within our day-to-day work. So particularly with victims of exploitation, we need to express professional curiosity in terms of our inquisitive inquiry, in terms of our questioning, and you know, further explore potential risk for victims. We need to make sure that there aren't missed opportunities to consider the use of the all-age exploitation screening tool. And as Jo said before, that it's not just a one-time screening tool, that it can be reviewed and repeated if need be. And it is a working evidence tool, and it's brilliant for evidencing risk. You know, by using that tool, we can categorically say that, you know, there are these risks in place and they need to be addressed in terms of safeguarding that individual. Quite a few contacts from professionals lacked the voice of the child. So when we say voice of the child, the documentation referred to particularly parental needs. The parents were spoken to, particularly for adolescents, and the adolescent's voice wasn't captured. We need to speak to that child, that young person or the adult on their own in order to make the safeguarding personal, to acknowledge the voice of the child. And as I say, there was a heavy reliance on parents and carers. During child's medical assessments and interventions, we were reliant on parents voicing their opinions, voicing their experiences, when actually it was the child or the vulnerable adult that was the victim. So we need to make sure that our documentation references the voice of the child and the adult, you know, to make sure that we are acknowledging them as victims and their experiences. Quite often no evidence of child and the adult being seen alone. We mentioned the value in seeing the victim alone. It gives them the opportunity to share, it gives them the opportunity to speak, and quite often we don't give them that opportunity now, whether that be through pressures in the workplace that we don't have that capacity, or we don't see that we've got that capacity. But we need to make sure that the child and the adult are seen alone where there are known exploitation concerns and risks. One particular case comes to mind was that a pregnant lady was actually a victim of exploitation, and she became pregnant as a result of trafficking and modern day slavery. And she was seen by the midwives repeatedly for antenatal contacts, and she was always accompanied by different men. She was never seen alone. She said that the people that were present were her uncle, were her brother, you know, cousin, friend, and actually she was never spoken to alone. Had she have been seen alone, it would have given her the opportunity to speak around her exploitation experience and the abuse that she was actually a victim of. So please bear that in mind when we are seeing victims and potential victims of exploitation. A lack of information sharing, we've repeatedly sort of highlighted that issue. So the lack of information sharing was between health and partner agencies, both from a health point of view and then also from partner agencies' point of view where health weren't informed. And sometimes obviously from a health point of view, you know, it might be that health weren't then sharing information with the relevant agencies that they should be. So it works both ways. But there's a heavy reliance on obviously that two-way conversation in terms of partner agency working. But particularly social worker and health liaison was quite often missing. So it's just to highlight the importance of allocated social workers liaising with dedicated health lead agencies that are working with that victim. And there was a minimal evidence of use of FIB forms, so Force Intelligence Bureau forms to share information. The first video, the video that we showed, touched upon intelligence information sharing from the police. So the Force Intelligence Bureau forms are accessible via West Midlands Police on their website, and you are able to share intelligence information with West Midlands Police, you know, anonymously. You don't need to obviously put your details on, but if it contributes to the triangulation of information in terms of disruption of exploitation, then that's always beneficial if you feel that, you know, exploitation is occurring somewhere or you have information to suggest that.
And Sarah, can I just say that Denise has added into the chat about more information about the FIB form can be found on the Solihull Safeguarding website as well. She's put the link in there.
That's wonderful.
I think the FIB
Thank you so
form's on
much.
there as well. Thanks.
That's wonderful. Thank you. As I say, it is accessible via West Midlands Police if you just Google it as well, but it's even easier for you to save that if Denise has put that in the chat. Thank you, Denise. So again, we're just continuing just with the last few points with regards to the findings from the audit. The audit obviously referenced the lack of knowledge regarding ongoing exploitation risks, including NRM status. And one of the fundamental issues was that health were quite often not invited to MACE meetings. And when they were invited, there was possibly a delay in that invite being sent out. Or it might be that when health were invited and they couldn't attend, that they subsequently didn't receive the minutes from the MACE meetings, so they didn't have the information that was discussed or the risk that was identified. And that's really important that we share that information with health following a MACE meeting. Many victims we know have health needs, so it's fundamental that health are part of the multi-agency adult and child exploitation meetings, and that could be anything around ADHD and anxiety, depression, PTSD and so on. Minimal evidence to suggest health invites from the local authority and involvement in broader multi-agency safeguarding discussions, so not necessarily just MACE as well, but, you know, professionals meetings that might have taken place. And again, there was a time delay in the liaison with health professionals from other agencies as well. So we are nearing the end, you'll be pleased to hear, without us talking. What all agencies need to consider at every contact. So this is from learning from local and national reviews and audits. So we've mentioned the all-age exploitation audit from Solihull, but this also captures learning from local and national reviews as well, both child safeguarding practice reviews and safeguarding adults reviews where children and adults were victims of exploitation. So we've mentioned around every contact counts and the reachable, teachable moments, identifying the opportunities to implement in all settings. So, you know, that might be that a reachable moment might be in A&E. It might be when that person, the victim, might be arrested. You know, the victim of exploitation, you know, may well be arrested for carrying drugs, for trafficking drugs from one place to another, from concealment and so on. Return to home meetings. So when that person has been missing, that victim, and they return home, that we need to make sure that's a reachable moment, that we have that contact with them in order to make every contact count and get their views. And it might be at various other appointments. Need to consider, we've mentioned all multi-agency working. the notion of think child, think family. So don't just think about the child or the victim, think about the wider family impact and support that's there or might not be there. What else needs to be put in place to support that victim at that point? They may well have no support at all. So that would be your responsibility as a professional to look at what agencies you can refer to. We've mentioned a few of the charitable organisations, but what other agencies could offer support that you can signpost to? We've mentioned the voice of the child and the adult, so listen to the children, young people and adults, ask questions and make the victim feel safer, offer reassurance, but also reiterate to them that what they are telling you cannot be held in confidence, you cannot not report it. You have a duty of care to report risk, to report abuse. So don't offer false promises to the victims in terms of a safeguarding. Make safeguarding personal. Joe's touched on that in terms of the adult response. And as a professional from whatever agency you're from, is we need to act as an advocate for the victims. Information sharing, we've said, particularly with health, is pivotal. Remember your NRMs and FIB forms. And we've said be professionally curious and offer inquisitive inquiry, be, professionally challenge, consider the lived experiences, offer a trauma-informed response. And the last few points were really important, from all agencies, is, escalate if you feel that, this case reaches a higher threshold than you're happy with, that where it's currently sitting, is escalate that within your own organisations. Your own organisations will have an escalation policy. You can refer to Safeguarding Safeguarding Adults Board and also local safeguarding children's partnerships for escalation policies. And there might be a need for supervision and oversight of an exploitation case, so utilise supervision in the workplace. It's there for a reason, for you to debrief, for you to gain expertise and advice in terms of management of a case. In terms of referrals, so if you're making a referral when you've completed the all-age exploitation screening tool, include as much information on that referral or that screening tool as possible. We need to make sure that we can check out wider intelligence, undertake lateral checks and talk to other agencies and professionals as part of that information gathering process. And really don't wait for crisis point. We've mentioned about early help, but from a health point of view, we always say don't wait for a reactive response. We don't want to get to a point where we're suddenly reactive. We don't want to wait for crisis. We want to intervene early. And if a victim is at immediate risk of harm, we would say contact the police, adult children's social care, and they're in an emergency out of hours duty contacts as well. And you will all have your own safeguarding leads for your organisations. So the action is for all of you to really be aware of the value of health input to support the work that you're doing. We're not the forgotten partner, and we hope to contribute to the work that you're doing and support that and work in partnership. Invite health professionals to exploitation meetings particularly, and any conversations that you have in terms of potential exploitation risk around children, young people and adults. Lead health professional ideally to attend and then to liaise with other professionals and partner agencies as required. Spot the signs, assess the risk using the tools, screening tools. We've mentioned early intervention, information sharing, seek safeguarding advice, inform a member of staff, make appropriate referrals and utilise safeguarding adult boards, information and local safeguarding child partnerships as well for information on policies and procedures and guidance locally. Documentation, we can only reiterate that the documentation needs to be timely and accurate, informative, relevant and factually correct. Share information and seek additional safeguarding training. If you feel there is a gap in your knowledge around exploitation, around safeguarding, in the role in which you're undertaking, then seek out additional training to support that. And the main thing is the 5 R's at the end. Keep this in the back of your mind around recognition, respond, report, record and refer. So those are the 5 things that we would always say keep in the back of your mind when dealing with exploitation and particularly any other safeguarding cases. And then final thoughts, we wanted to just capture the discussions, obviously, the things that we've mentioned in today's webinar, that safeguarding, exploitation is a safeguarding issue, and health professionals play a key role. And the inclusion of health professionals is crucial in the multi-agency response in tackling exploitation. Consider the benefit of conversation, the inclusion, the partnership with all agencies. Ultimately, it only informs your own practice, it only benefits and supports your own practice, and the management of the case can only benefit the victims in terms of agencies working together. Without us working together, it's to the detriment of the victim of exploitation. And really just to appreciate and value every professional's contributions and expertise. We've all got different experiences. We've all got a lot of different expertise and knowledge that we can bring to the table. So the main thing is working together to tackle exploitation and not excluding partners, and valuing the input from everybody. Finally, before we go to any questions, I think it was just we wanted to share the support and signposting that you can access. There are some charitable organisations there that you may or may not have heard of. The websites are there for you to further explore those if you haven't done, that are working in the Solihull area that you may know. And there are many different others as well, that they aren't just the only ones, but those are the ones that we've added into this particular one from a health point of view for Solihull. Our contact details are there, so Birmingham and Solihull CCG, so the clinical commissioning group for the NHS for Birmingham and Solihull, the website is there. We offer a safeguarding advice and support line to providers only, so the providers would be services that we commission within Birmingham and Solihull, so that's a non-emergency contact in terms of advice for safeguarding. But should you require safeguarding advice in your own organisations, please speak to your managers and individual departments, because they will be able to signpost you to the relevant areas for support and advice if you need it relating to an exploitation case. Our contacts are at the bottom should you wish to speak to either myself and Anjana. We're based obviously at the CCG, Birmingham and Solihull CCG, and Joe is based at Birmingham and Solihull Mental Health Foundation Trust as well. But as I say, the slides will be sent out and available for you afterwards. Any questions? I think we'll use this opportunity to answer any questions that people have. Is there anything that's popped up in the chat, Joe or Anjana?
Yeah, Denise has shared all age exploitation awareness training dates that are available, and she's shared the link there. So if anybody's interested in any further training, I'd recommend that you have a look at that link.
That's wonderful, thank you. I'm just going to share as well at the very end here. There's you just go into here. There's a link that I'm going to share around appropriate language in relation to child exploitation, which is really useful. It's a recent document that you can access. I've just popped it in the chat there. It's from the Children's Society from this year, and that's quite useful in terms of appropriate language to use with children and victims of exploitation. And there is one more that I'm just going to look at. There it is. So this is the County Lines Exploitation Applying All Our Health is the document, and it's got various links in that you might find useful in your day-to-day practice as well. So a number of different documents for you to amuse yourselves with on a Wednesday evening. I'm sure you would enjoy to read the heavy reading that surrounds exploitation, but it is there for your reference, so please feel free. Please feel free to pop questions in the chat if you so wish. Denise, is there anything else you wanted to add, or Rachel?
I'd just like to say thank you to you. We've tried to pop things into the chat that are relevant as you've gone along. So we did pop in the language guide that we've got within the all age exploitation procedures. So we have a guide for working with children and adults about the language that's used in Solihull. So we've popped that in. We popped in the links to the screening tools and the procedures. The link to the FIB form not only has the FIB forms in, but it also has a presentation explaining what the FIB form is, in case anybody's wondering what happens to it and how it works. So there's a presentation on that page as well that explains what that is. And we've just put other links to some videos and things that complement what you've said. So we will try and make sure that the chat is shared along with the presentation. And as we said, this has been recorded, so hopefully we'll be able to make the recording available as well. Does anybody have any other questions that haven't been
Sasha's put a question in the chat. How likely do you think it is that there will eventually be a singular system for all agencies to share information? And what impact do you think this would have on tackling exploitation?
Oh wow, that's the question we get asked so often. And anybody that was around years ago, in like sort of my age, we were once promised by one government, even people might remember, that we were going to have a system that would flag all children, and we all had to put money aside in our budgets to pay for that. So that, and then the government changed and off it went, and it's never come back on to the system again. I think with the challenges of information sharing and security at the moment, it doesn't look likely to rear its head, but I can understand why many people ask it. The one thing I'd say is, though, systems aren't everything. Information sharing is often more about communication than just recording something on a system. And as much as we need to make sure things are recorded accurately and they are there and they're available for people to see, the most helpful thing in safeguarding is often communication, where people are actually speaking to other people or communicating and understanding and responding to what is said rather than just firing emails.
Absolutely, and I think having one system, Denise, would be the dream for us all, wouldn't it, in many ways? But also I think there are many challenges that come with that, because I think we would end up trawling through hundreds and hundreds and hundreds of pages of contacts potentially to get to the information that we want. So it is around
and acronyms in different
exactly.
services. Things that people use for shorthand in one service could mean something completely different in another service, and could send alarms going off all over the place. So yeah, I think that's a long way off, if ever, I would suggest.
If ever, I would agree. Yeah, it's a challenge in itself, I think. But no, I agree. I think, you know, the key is communication across all agencies, and we need to make sure that we have this jigsaw that joins up, and we don't have these missing pieces. And without the communication and the partner agency working, we sadly do have those gaps.
The one thing I'd try and think about, I think with agencies working together, we want to make sure that we're all talking together and there's many of us involved. Sometimes that's overwhelming for families and children and young people and adults. So sometimes we need to think about how do we minimise the amount of people that are having to have contact with the individual person while maximising that we're all talking to ourselves. And I think that's quite an important thing to remember.
Absolutely.
And I guess on that line as well, it's about people having to repeat their story. I don't know whether we mentioned that earlier, I can't remember, but you know, that can be really disheartening for people, can't it, if they're having to say time and time again, you know.
Re-traumatizing.
And if you're actually being controlled by somebody who's telling you where and when you've got to be all of the time, and then you've on top of that got 7 statutory professionals and so many other voluntary agencies that people are signposting you to, you're never going to remember where you're supposed to be at any one time. And the more services that are involved, the more the abuser gets a chance to isolate that person, because the person doesn't know who they're supposed to go to. So we need to think about how we focus on a link person, minimising the amount of people that person has to think about, so that it's easier for them to make those contacts.
Definitely. So I don't know whether anybody else has got any questions. Please feel free to raise any hands, or, you know, pop anything in the chat just for the last few moments.
Lots of people saying thank you very much for an informative presentation, and especially for the links as well. The people have found that really helpful.
You're very welcome. I hope they are useful, because we all know that I think in the day-to-day jobs that we're doing, we quite often don't get chance, or we're not aware of any new documents. They get emailed to us, but then it's having the time to actually read them. You know, I'm guilty of that as well. But yeah, hopefully it saves you looking for them and searching for them if they're there. So if they're useful to one person, that's good enough for me.
So thank you everybody for your time, particularly thank you Sarah, Joe and Anja. Thank you very much indeed for your presentation today, and we look forward to seeing you all in future presentations.
No problem. Thank you.
Thank you.
Thank you all.